pre-invasive papillary cancer, or the breast, ductal carcinoma in situ, or lobular carcinoma in situ, does not extend beyond the basal membrane. Metastasis is a pathogenic agent, usually tumor, spread from initial or primary site to a different or secondary site within the host's body. His uncontrolled proliferation by mitosis produces a primary heterogenic tumor. The cells which constitute the tumor eventually undergo metaplasia, followed by dysplasia, then anaplasia, resulting in a malignant phenotype. This malignancy allows for invasion into the circulation, followed by invasion to a second site for tumorigenesis. Here we see on this picture malignant tumor. Cells invade normal tissue and either blood or lymph metastasize from distant sites. And on the right part of this picture we have seen that this part of cells invade into the vessel and self-sustained into the vessels and go to another part of the human body and grows there. Metastasis occurs by the following four routes: transcollomic, lymphatic spread, hemogenous spread, and canalicular spread. Transcollomic. The spread of the malignancy into body cavities can occur via penetrating the surface of the peritoneal, pleural, pericardial, or subarachnoid spaces. For example, ovarian tumors can spread transperitoneally to the surface of the liver. Lymphatic spread. Lymphatic spread allows the transport of tumor cells to regional lymph nodes near the primary tumors and ultimately to other parts of the body. This is called nodal involvement, positive nodes, or regional disease. Positive nodes is a term that would be used by medical specialists to describe regional lymph nodes that tested positive for malignancy. It is common medical practice to test by biopsy at least one lymph node near a tumor site when carrying out surgery to examine or remove a tumor. This lymph node is then called a sentinel lymph node. Localized spread to regional lymph nodes near the primary tumor is not normally counted as a metastasis, although this is a sign of the worse outcome. Hematogenous spread. This is typical route of metastasis for sarcomas, but is also the favorite route for certain types of carcinoma, such as renal cell carcinoma, originated in the kidney. Because of their thinner walls, the veins are more frequently invaded than are arteries, and metastasis tends to follow the patterns of venous flow. That is, the hematogenous spread often follows distinct patterns depending on the location of the primary tumor. For example, colorectal cancer spreads primarily through the portal vein to the liver. First of all, it's clonal expansion, growth, diversification, and metastasization. Adhesion to and invasion of the basement membrane. Passage through extracellular matrix, invasion, interaction with host lymphoid cells, tumor cell embolus, adhesion to basement membrane, extravasation, metastatic deposit, angiogenesis, and growth. Canalicular spread. Some tumors, especially carcinomas, may metastasize along anatomical canalicular spaces. These spaces include, for example, the bile ducts, the urinary system, the airways, and the subarachnoid space. The process is similar to that of transcollomic of a canalicular system and one metastatic process of, in fact, independent tumors caused by the same agent, field cancerization. Here we see that some malignant tumors have some favorite space where they want to metastasize. So for the lung cancer, it's bones, liver, brain, lymph nodes. You must understand, for every type of the cancer, one exception from this rule is uh, skin cancer. It didn't metastasize, and adrenal glands, basal cell cancer type of the skin cancer didn't metastasize. And favorite sites of breast cancer, it's brain, lung, liver, and bone. According to the level of histological differentiation, there are highly differentiated tumors. By structure and function, the tumor tissue is closest to its normal counterpart. Cellular atypism and polymorphism in them are poorly expressed, and tendency to grow, invasion, and metastasis does not reach the maximum level. G2. Moderate differentiated tumors. These indications are more pronounced the degree of malignancy above. Low-grade tumors, atypism, polymorphism, rapid invasive growth, metastasis, and expressed especially strong, which is realized in more significant malignant potential. And G4, sometimes in some Russian sources, G4, which denotes undifferentiated tumors. Its highest growth potential of all above. TNM classification. Clinical TNM stages, or CTNM, which mean clinical, is based on information gained up until the initial definitive treatment. And pathologic staging, PTNM, includes clinical information and information obtained from pathological examination of the resected primary tumor and regional lymph nodes. So, primary tumor. The clinical measurement of tumor size is the one judged to be the most accurate for each individual case based on physical examination and imaging studies. For example, in breast cancer, the size of the tumor could be obtained from a physical examination, mammogram, or ultrasound, and the tumor size is based only on the invasive component. For example, on the right picture you can see different stages of the urinary bladder staging, and we have different points in the different types of malignant tumor. On the either, most of all times it's hollow organs. Stage of G belongs to the stage of invasion into the tissue or the whole organ or the surrounding tissues. But if we talk about breast, for example, it can be only size of the tumor which differentiate which stage it is. Note: if even one lymph node is involved by tumor, the N component is at least N1. For many solid tumor types, simply the absence of or presence of lymph node involvement is recorded, and the tumor is categorized either as N0 or N1. For all the tumor types, the number of lymph nodes involved, the size of the lymph nodes or the lymph node metastasis or the regional lymph node basin involved also has been shown to have prognostic value. Metastasis. Cases in which there is no distant metastasis are designed M0. Cases in which one or more distant metastases are detected are designed M1. In all cases of tumor staging, if we don't know exactly some part of the classification, we can write X, for example. If we didn't have results of node biopsy, we could write NX. Tissue-specific classification. We have epithelial tumors, so we have organospecificity. Epithelial organ-specific and glandular tumors, mesenchymal tumors, tumors of the melanin-forming tissue, tumors of the central and peripheral nervous systems and membranes of the brain, neuroectodermal and meningovascular. 6. Tumors of the blood system, hemoblastosis and teratomas. Clinical diagnosis. As every patient which examined, we must take from him history of the disease, inspection, palpation, percussion and auscultation. We must understand about very important part is paraneoplastic syndromes. Paraneoplastic syndrome is a syndrome that is consequence of cancer in the body, specifically due to the production of chemical signaling molecules such as hormones by tumor cells or by an immune response against the tumor. We have endocrine, neurological, mucocutaneous and hematological types of paraneoplastic syndromes. So, endocrine syndromes, it's Cushing's syndrome, syndrome of inappropriate antidiuretic hormone, hypercalcemia, hypoglycemia, carcinoid syndrome, hyperaldosteronism. Neurological, Lambert-Eaton myasthenic syndrome, paraneoplastic cerebellar degeneration, encephalomyelitis, limbic encephalitis, brainstem encephalitis, opsoclonus myoclonus ataxia syndrome, anti-NMDA receptor encephalitis, polymyositis, mucocutaneous, acanthosis nigricans, dermatomyositis, laser triad sign, necrolytic migratory erythema, Sweets syndrome, florid cutaneous papillomatosis, pyoderma gangrenosum, and acquired generalized hypertrichosis. Hematological, granulocytosis, polycythemia, trousseau non-bacterial thrombotic endocarditis, and anemia. Others: membranous glomerulonephritis, tumor-induced osteomalacia, Stafford syndrome, neoplastic fever, and tumor-associated multi-organ autoimmunity. Tumor markers. It's very important lab findings. A tumor marker is a biomarker found in blood, urine, or body tissues that can be elevated by the presence of one or more types of cancer. Uses of tumor markers. First of all, screenings for common cancers on a population basis. Broad screening for all the most types of cancer was originally suggested, but has since been shown not to be a realistic goal. Screening for specific cancer types or location requires a level of specificity and sensitivity that has so far only been reached by example. Elevate prostate-specific antigen suggests that it is used in some countries to screen for prostate cancer. Monitoring of cancer survivors after treatment. Detection of recurrent disease. Example: elevated alpha fetoprotein in a child previously treated for teratoma suggests relapse with endodermal sinus tumor. Diagnosis of specific tumor types, particularly in certain brain tumors and other instances where biopsy not feasible. Confirmation of diagnosis to verify the characteristics such as size and aggressiveness of the tumor and thereby to help in the evaluation of a suitable treatment schedule. Staging. Some tumor markers are included in the staging procedures for some tumor localization. And prognosis. To plan the treatment when used pre-treatment and to help the patient plan his future when used after the operation occurs. To verify the effect of treatment, to change the treatment if ineffective. As companion diagnostic to verify if the treatment is suited for the type or subtype of tumor, particularly in personalized medicine. Here we see different types of the tumor markers and how it's described. And here you see specific tumor markers which are used for different organ cancers. Biopsy. Biopsy is a medical test involving extraction of sample cells or tissues for examination to determine the presence or extent of a disease. Types of biopsy. First of all, needle biopsy. Most biopsies are needle biopsies, meaning a needle is used to access the suspicious tissue. We can use it in the histologic inspection. Aspiration biopsy. A needle withdraws material out of a mass. This simple procedure is also called thin needle aspiration, and we can take not part of the tissue, we can take only different cells. So further examination will be cytology. Surgical biopsy. Either open or laparoscopic surgery may be necessary to obtain a biopsy of hard-to-reach tissue. Either a piece of tissue or the whole lump or tissue may be removed. And smear. Abnormal findings are often followed up by more sensitive diagnostic procedures and, if warranted, interventions that aim to prevent progression to cancer. Surgical biopsy. We have two different types of biopsy. It's excisional and incisional. During an excisional surgical biopsy, the surgeon will attempt to completely remove the area of concerned lesion, often along with the surrounding margin of normal tissues. An incisional surgical biopsy is similar to an excisional biopsy, except that the surgeon only removes part of the lesion. Incision breast biopsy is usually only performed on large lesions. You must remember, never take a biopsy from a lesion which looks like melanoma. It means you will never take a biopsy incisional. You can make excisional biopsy from melanoma, but you must go out from the border of the melanoma for 2.5 centimeters. Another types of biopsies is CT guided biopsy. A person rests in a CT scanner. The scanner's images help doctors determine the exact position of the needle in the targeted tissue. And ultrasound guided biopsy. An ultrasound scanner helps a doctor direct the needle into the lesion. We have specific types of biopsy. Liver biopsy. A needle is injected into the liver through the skin or on the belly, capturing liver tissue. Kidney biopsy. Similar to a liver biopsy, a needle is injected through the skin on the back into the kidney. Prostate biopsy. Multiple needles biopsies are taken at one time from the prostate gland to reach the prostate. A probe is inserted into the rectum. Skin biopsy. A punch biopsy in the main biopsy methods is used a circular blade to get a cylindrical sample of skin tissue. Bone biopsy. A bone biopsy is used to look for cancer of the bones. This may be performed via the CT scan technique or by an orthopedic surgeon. Bone marrow biopsy. A large needle is used to enter the pelvis bone to collect the bone marrow. This detects blood diseases such as leukemia or lymphoma. Also, we can use a scintigraphy. You read about this in the earlier lectures about about X-ray methods in surgery and position emission tomography. You can pause this video to read another time. This is example of the contrast PET scan, and we have SPECT. You can make this video on pause and read another time. CT scan and MRI. And we have 4 different and important principles of oncosurgery: aplastic, antiplastic, anatomic zones, and the case, or principle of Futler in Russian. Aplastic principles of surgery that prevent rejection and migration of tumor cells and their complexes through the blood vessels and/or leaving them in the wound. The basis of aplastic is removal of the tumor within healthy tissues. Antiplastic complex of measures for removal of the wound tumor cells or to destroy them. The principle of antiplasticity is proved by the use of various chemical and physical factors during the operation in order to have a destructive effect on the affected areas in the wound of a tumor cell. Anatomic zoning removal. The principle of anatomic zoning removal of a tumor within obviously healthy tissues. The tumor growth zone in a single block with surrounding tissues and regional lymph nodes, the metastasis zone, in the basis of radical operation. The principle of the case. The principle of the case means the tumor is removed within exposing its surface, but in a common block with covering peritoneal, pleural, facial leaves, muscle, fat or skin, in a complete case of healthy tissues, blood vessels entering or exiting the area of the case intersects outside of it. Treatment. Although surgery is an effective therapy for most solid tumors, patients who die from cancer usually die of metastatic disease. Therefore, to improve patient survival rates, a multimodality approach including systemic therapy and radiation therapy is key for most tumors. So we have different types of treatment: surgical, chemotherapy, radiation therapy, hormonal therapy, targeted therapy, immunotherapy, and gene therapy. Targeted therapy. Over the past decade, increased understanding of cancer biology has fostered the emerging field of molecular therapeutics. The basic principle of molecular therapeutics is to exploit the molecular differences between normal cells and cancer cells to develop targeted therapies. Thus, targeted therapies usually are directed at the processes involved in the tumor growth rather than directly expressed in the cancer cells, be the driving force of the proliferation of the cancer cells and be critical to the survival. A large number of molecular targets are currently being explored both preclinically and in clinical trials. The major groups of targeted therapy agents are inhibitors of growth cell factors receptors, inhibitors of intracellular signal transduction, cell site inhibitors, apoptosis-based therapies, and anti-angiogenic compounds. Immunotherapy. The aim of immunotherapy is to induce or potentiate inherent anti-tumor immunity that can destroy cancer cells. Central to the process of anti-tumor immunity is the ability of the immune system to recognize tumor-associated antigens present on human cancers and to direct cytotoxic responses through humoral or T cells mediated immunity. Gene therapy. Gene therapy is being pursued as a possible approach to modifying the genetic program of cancer cells as well as treating metabolic diseases. The field of cancer gene therapy uses a variety of strategies ranging from replacement of mutated or deleted tumor suppressor genes to enhancement of immune responses to cancer cells. And combined treatment. Under combined treatment, we understand the combination of any two types of treatment: surgery plus chemotherapy or plus radiotherapy. And when we talk about complex treatment, it means we use surgical, chemotherapy and radiation therapy at once or all together. We have another very important definition and classification. Clinical groups help doctors to analyze the situation with patients in the specific region of the country. We have clinical groups. First clinical group, it's people, first A, with precancerous diseases, actually healthy. First A patients with a disease suspected of malignancy. As the final diagnosis is established, they are removed from the register and transferred to other groups. And 1B patient with precancerous diseases. Second, clinical group, persons with proven malignant tumors that are subject to radical treatment. And third, clinical groups, individuals with proven malignant tumors who have completed radical treatment and are in remission. They stay in this group for 5 years. And then they lose their clinical groups if cancer didn't recur. This patient lose their clinical groups, and we look at this patient as to a healthy patient. Fourth clinical group, it's persons with proven malignant tumors which for one reason or another are not subject to special anti-tumor treatment but are subject to palliative treatment. And thank you for your attention.